memorizing my 23andMe results for testing purposes or just in general. So there is information that we don't include on the exam. So why do I put on the syllabus classes 2 to 14? Well, that's if anything changes. I want to make sure that I have included those because I can always get rid of them, but adding more, I feel like it's a little bit more traumatic to the schedule than just removing information. So what I have tried to do with this is highlight those lectures or the material within the content that we went through that would be presented on an exam. So for example, the second class we talked about fundamentals of human genetics, basic fundamentals, DNA, RNA, coding, what is the reference sequence, what does that mean? Information like that is valid for an exam. It's very important because once you get out there in the field and you see this information, you need to be able to decipher it for the proper clinical care of your patient population. In lectures 3, 4, and 5, lectures 3 is where we talk about direct-to-consumer testing. That's just sort of a fun example, and you guys have assignments for homework where you start to think about this, process this type of information. So there's nothing really there that is what I would consider testable material. Same with the superhero tips and the super tasty genetics. So these are just examples. So I have X'd these out because I'm not going to go back through that material and see what questions I could grab for an exam. Didn't do that last year, I'm not going to do that this year. The genetics effects on metabolism, and then the genetic and pharmacogenetic tests like the cholesterol, metabolism, those would be. And then 8 and 9 are a little different. As you know, 8 and 9 are what I consider some of the most important take home or take out of from this course material, because that's where you're using Pharmacogenomics, CPIC, FDA guidelines. Those are the kinds of things that you would be expected to use out there in the clinic when you're practicing in practice sites. However, I haven't figured out a way to make that testable material and give you access to the internet during your exam without having the possibility of, obviously, the Google, Oracle, you have all access to all types of information. So what I try to do is give those assignments so that you are familiar with those data sets. But for testing purposes, I won't be writing questions except I have little tiny highlights here. And that's for, I want you to know the names of the resources. Okay, so know the names of the resources. So if I had a fill-in-the-blank question that said, give me the name of a pharmacogenomic database that you would access to look up patient information, I would expect you to fill in the blank with something like Pharmacogenomics, CPIC. If it was more specific about some sort of labeling or companion diagnostic, the overview of the FDA information from lecture number 9 would be the website to go to for that. So those are all little resources for pharmacists in particular to use as references in their practice sites. So I would just expect you to be familiar with the website, name of the website, what resources you have. So that's it for 8 and 9. 10, 11, 12, 13, 14, this is more content-oriented. CYP 2C19, CYP 2D6. Today we'll talk about CYP 2C9. And for now, I have highlighted 13, but I'll keep you posted because some of this content is going to be similar to other exercises that we've done. So I'll keep you posted about 13. And then 14 will be a recorded lecture. So next week, we will only meet on Tuesday. We will not meet on Thursday. You guys have other activities to do as a class. And so that will be recorded. And that's all the content for the midterm exam. So you're not responsible for everything we've done, everything we've talked about. Does that clarify things? It's a great question. One of your colleagues emailed me, and so I thought as a class, if we went over it, that would help sort of guide your studies and make it so that certain material is irrelevant. What about knowing some of the alleles and subgroups? For right now, I would say yes, on the important alleles or subgroups, meaning like I would say, what is star one on an exam, and you would be expected to know that's wild type. But it would only be the most common alleles that we've discussed, which is usually about 4 approximately per condition. And that would be from so far just the 3 lectures. Now, if that changes again, I'll let you know. I haven't written the exam yet. And so if I wanted to write some really fancy questions, then I might have to give more information, and we would disregard that. But as of right now, that's my thinking. Are there other sort of follow-up questions? And I can't give any information about formatting yet, because as I said, I haven't written it yet. But we'll get to that. And as you note here, there is an exam review session. So by here, I will have written your exam, and we can go over more specific questions at that time. But I thought that was an excellent question, and it was time to discuss and time to go over that and make clear that super tasting genetics, things like that would be on the exam. All right, well, if there are no more specific questions about that, then let's go into the pharmacogenetics of anticoagulants. Yeah, if there's any questions from distant sites, just speak up. All right, so today we're going to talk about warfarin. Warfarin has a well-established role in the secondary prevention of atherosclerotic disease, reducing new thromboembolic events. But as you guys know, you're very familiar with this drug, there's a lot of risks, and there's a lot of adverse effects for warfarin. It has a very narrow therapeutic range, so it requires meticulous monitoring and very, very specific dosage titration. I'm sure you guys are all aware of that. What we're going to talk about specifically today are how the genetics of patients apply to this, and moving towards, based upon the genetics, dosing specifically, and using guidelines for dosing recommendations based upon the DNA and the genetics of a particular patient. The appropriate dose of warfarin is difficult to establish because it can vary by a factor of 10 amongst patients, and the consequences of taking an incorrect dosage can be catastrophic. So in 2007, the FDA stepped in and then put in pharmacogenomic information to the warfarin product. So it actually added that to the label, so that now we can be more careful and more specific about dosing and dispensing of this drug. So we'll talk about CYP2C9, talk about its role in the metabolism of warfarin. We'll also talk about VKORC1, vitamin K activation, and that being a target of the drug warfarin, so for the mechanism of action. The genotypes, of course, the star 1 alleles are the normal, also known as extensive, also known as wild type metabolizers. We'll look at how the guidelines affect dosing, and again, specifically for warfarin, because this is on the FDA biomarker list, and it's an actionable drug in terms of the pharmacogenomics or the pharmacogenetics. And so when I try to craft my visual to describe what we're going to talk about, warfarin is an anticoagulant. So that is, of course, the mechanism of action of the drug, which I assume you are all very familiar with. And so what we're looking at in the genetics is that when we dose this, so this is a low dose all the way to, a low function of anticoagulant activity all the way to a really high function, right? We want to hit the sweet spot, which is right here in the middle. But it's different for a lot of people based upon the genetics. If we don't get it right and our anticoagulation is too low, then we have thrombosis. And if we go too high with our anticoagulation, then of course we have bleeding. And bleeding has to be treated, and there are guidelines surrounding this, of course. And so what we're aiming for is to use the genetics to guide our dosing so that we can get this right. So on the warnings and precautions, of course, it says that Coumadin can cause major or fatal bleeding. There is management of bleeding and excess anticoagulation, have a lot of guidelines to major bleeding, stopping warfarin, and basically giving vitamin K1 by slow intravenous injection, taking the patient off warfarin, and then for 2 weeks they can't go back on it, and again, a lot of guidelines to treat and correct that problem. They also need to perform regular monitoring of the international normalized ratio in all treated patients, and instruct patients about preventing measures to minimize the risk of bleeding and to report signs of symptoms of bleeding. Warfarin is the most commonly used oral anticoagulant worldwide. Of course, we do have alternatives to this as well. There's over 30 million worldwide prescriptions a year, and they estimate that in the Western world, approximately 1% of the population is prescribed warfarin or something very similar. So although it's highly efficacious, the dosing is notoriously challenging due to the narrow therapeutic index and the wide inter-individual variability of the dose requirements. So complications from inappropriate warfarin dosing are among the most frequently reported adverse events to the FDA and one of the most common reasons for emergency room visits. We want to get to a stable dose to achieve an international normalized ratio between 2 to 3 range from anywhere from 1 to 20 milligrams per day. It's usually dosed empirically, an initial dose is prescribed, typically followed by at least weekly measurements of the INR and subsequent dose adjustment. So what is warfarin doing in this case? Warfarin is a mixture of stereoisomers. We have the R and the S. The S being 3 to 5 times more potent than the R stereoisomer. And the S, not only is it more potent, is the one that is predominantly metabolized by CYP2C9 into its inactive metabolites. And so this is one of the reasons why variations in this particular CYP450 enzyme has such an impact on warfarin and Coumadin dosing and outcomes. There are also common genetic variants, not only in the CYP2C9, but also in the target of the mechanism of action. So you're looking at 2 different variables here. This is the reason why I do not start out with this particular lecture. I like to start out slowly, where you're just looking at one variable in the equation. But with warfarin, we have 2 variables, and we have to combine the genetics of both to account for the dosing and the variability. So what is warfarin doing? You probably know it is antagonizing the vitamin K dependent activation of a range of coagulation factors. Factor 2, factor 7, factor 9, factor 10, and it's actually inhibiting the vitamin K epoxide reductase. So here is warfarin, and it's inhibiting this. In addition, the CYP2C9, as stated previously, was on the other slide, is also metabolizing warfarin, again, resulting from the S stereoisomer. CYP2C9 has over 60 known variant alleles. So there is a whole lot here, and probably a whole lot of information that we're missing. So if you need another plug to consider some research endeavors as a pharmacist, it's questions like this that we don't know, that we don't have a complete answer, that need more research and more understanding. On the next slide, we're only going to look at 25 of these, okay? Now, you're not going to be responsible for 25 or 60, so while there are 60 known variant alleles for CYP2C9, there are some that are more important than others. Why do I say that? Because they were discovered first, we know more about them, we know about their function. Of course, the star 1 allele is normal function. And then it's also important to know the star 2 allele, which I'll just go over this for testing purposes. So on the test, you could see something like a C. C is obviously for coding, right? In the DNA at position 430 in the coding sequence, we have a C that's shifted to a T. So that's the base pair. But what happens from that is that the protein, arginine, at position 144 in the protein sequence is then substituted for cysteine. And here is the reference sequence number of everything that's going on in that site. And this actually impairs warfarin metabolism by approximately 30 to 40%. Then we also have another allele that is important to know, and this is CYP2C9 star 3 allele. So the coding region in the DNA at position 1075, the adenine becomes cytosine. And as a result of adenine shifting to cytosine as a DNA in the base pair positions, the protein isoleucine at position 359 is then substituted for leucine. And this is the reference sequence number that has all that information. So this actually impairs warfarin metabolism a lot more. So this one, 3, is much worse functionally than star 2. So even though up here in this table it gets generalized, they're decreased in function, they're not all created equally. So this SNP has a decrease by about 80 to 90%, obviously affecting a lot more. But also take note, like in the exam, you're not going to need to know 16 through 25. But look at all this sort of incomplete information. No function, unknown function, uncertain function. And again, these are things like in research questions we typically try to go after as scientists. Specifically to say, okay, well, what exactly does this do? What is its role? It's in the DNA, it's there, showing up, but does it have any effect? So here are also phenotypes based on CYP2C9 diplotype. So this is from Pharmacogenomics. So with the likely phenotype of an extensive metabolizer or normal activity, this for CYP2C9 is going to constitute the vast majority of patients, right? 91%. And this is an individual that, as far as the diplotype, would be star 1 allele. And this, again, is normal. Now, star 2 is decreased. And here they've just abbreviated. So instead of saying arg to cyst, like arginine to cysteine, arginine, the abbreviation for that, or the symbol is R, at position 144 is cysteine. So they're just sort of abbreviating these amino acid changes here. So don't let that throw you off. And again, this is DNA over here. DNA versus protein. So an intermediate metabolizer, we have heterozygotes for intermediate activity. This constitutes approximately 8% of patients. Could be a star 1, star 3, or star 1, star 2. And then if we have star 2, star 3 combinations, this is a poor metabolizer. Homozygous variant, low or deficient activity. This constitutes a very small percentage of patients. But again, even though that's small, we're talking about 2 different factors here, and the other factor has even more variability. So we have to combine those to see what is happening in the specific patient population. We also have very different expression profiles in ethnic group frequencies. And so this is the kind of information that I do like to include as testable material. So I will just give you a heads up on that. You'll have some questions today to try to give you a flavor or an example of types of questions, basically looking at that and what I just stated. So these guidelines are written with a global audience in mind, with the majority of data initially arrived from people of European ancestry, but now we're able to include more with African Americans, Middle Eastern, and Asian, Oceanian alleles. So what I have highlighted is the really relevant information. So when we look at star 1, the guidelines say that the vast majority of our patients are going to be extensive metabolizers. However, when we look at more details, we see that that may not necessarily be the case. When we're looking at Caucasian and Middle Eastern frequency, we see in the star 2 and star 3 alleles that we're likely to see that anywhere from 13% to 7% in that specific patient population. And in South Central Asian, about 10%. In America is 3 to 6%, so that's pretty low. Interesting thing is that East Asian population is different, right? Anywhere from 0 to 3%, very different than the 10% here. And in the African population, we do not see star 2 and star 3 alleles at all. So what do we see in the African population? We see almost exclusively in persons of African ancestry, star 5, star 6, star 8, or star 11, at lower levels, albeit. So exam, we're mainly concerned with these. But I do like to ask the typical question that if you saw alleles star 5, star 6, star 8, or star 11 in CYP2C9, predominantly or almost exclusively in what major race or ethnic group would that appear in? Because we see 0% in the others. So takeaway from this is that all populations could be affected. However, the alleles are going to vary in how those populations are affected. So as a consequence of genetics, individuals who inherit 1 or 2 copies of CYP2C9 star 2 or star 3 are at greatest risk of bleeding during warfarin therapy. They require lower doses to achieve similar levels of anticoagulation, and they require more time to achieve a stable international normalized ratio. Individuals with star 2 and star 3 alleles have reduced warfarin maintenance dosing, and variants with reduced activity, the star 5, star 6, star 7, star 8, and star 11 alleles have decreased warfarin maintenance dosing. But these variants are almost exclusively occurring in individuals of African ancestry. So this basically summarizes what I said from the previous slide. And then we also have the rare star 14, star 13. These are associated with decreased warfarin dose in Korean patients. Again, the takeaway is that all populations are affected, but the alleles will vary. Now let's talk about the other part of this equation. So not only do we have to consider CYP2C9, we also have to consider the human vitamin K 2,3 epoxide complex subunit 1, or VKORC1. This is the primary oxidoreductase enzyme that reduces vitamin K quinone to hydroquinone, functioning as the point of entry for vitamin K into the vitamin K cycle. So this is the target enzyme of warfarin, and this is essential to the production of blood clotting factors. So again, we have 2 different factors here, CYP2C9 and VKORC1. All right, so I'm going to spend a little bit of time here talking about the interplay between these 2 factors on pharmacogenetics and warfarin dosing. So warfarin is inhibiting one of these factors, VKORC1, which will vary in your patient population. It's also being metabolized by CYP2C9, which will also vary in your patient population. So the recommended starting dose, we started at 5, 3, 2, and 1. All right, I'm going to draw this out here. The starting dose, we're going to have a very specific calculator. What I'm trying to get at is the logic behind the calculator and how the genetics interplay in this calculator with affecting the dose. So down here, so y-axis, x-axis, we have CYP2C9 genotypes. These repeat AA, AB, BB, AA, AB, BB. And we also have VKORC1 genotypes. We have the homozygous variant BB, heterozygous AB, and the homozygous common AA. Okay, so the CYP2C9, AA is essentially star 1, right? So this is star 1, star 1, star 1, star 1, star 1, star 1. Okay? But again, you can have a wild type at one point and a homozygous common at another point, and that's going to decrease the dosing. And I'm going to keep going through this before I sort of back up to that. Then the VKORC1, the homozygous variant BB is essentially our star 1 allele. So this is for VK. Then our heterozygous, an example of that would be our star 1. I'm just going to give an example. This isn't the only way you would get to a heterozygous. For star 2 for VKORC1, and then for the homozygous, it would be star 2, star 2. We'll get to the base pairs on the next slide. Right now, we just want to look at the alleles, the overall alleles, not the base pairs specifically. So if a patient is a star 1 allele at both CYP2C9 and VKORC1, they're going to start at 5 milligrams, right? But again, they have very specific dosing calculators. So this is just to understand the interplay. Don't use this to dose a patient, okay? Just the interplay, just the basic overall concept. If you get this graph, you've got the concept down. Okay, now, if a patient is, let's say, a star 1, star 2, or maybe a star 3 for CYP2C9, but yet star 1 for VKORC1, they're going to start at a slight reduction. And this is going to be about 3.5 milligrams, or approximately 70%. Now what happens if we move on to the next group? So the next group, again, we could have a star 1 wild type at CYP2C9. So the metabolism is wild type. But we have a heterozygous VKORC1. So when we combine these factors, our starting dose would be about 2.5 milligrams. Or 50%. So the idea that you're just trying to get here is the interplay between these two factors. When they're both wild type, when one is wild type and the other one is mutation, or vice versa. Now we have a scenario where we're going to look at mutation or reduced function in both CYP2C9 and VKORC1. So in the case where we would see a mutation, a star 1, star 2 allele, CYP2C9, or a star 2, either way, and star 2 for VKORC1, this would then drop to about 30% of starting dose, and would be a little bit more than 1. I think this is around 1. So really we should say 20%. I think my note is wrong here. It's around 20% for a starting dose. But again, this is a conceptual. This is not where, okay, I'm going to look at this graph and dose patient. We're going to use a calculator. It's very specific. It's all been worked out for this kind of stuff. It's just the concept of what happens to the dose when I have these genetic factors coming together. Again, if we have too little anticoagulation, we have thrombosis. If we have too much coagulation, we have bleeding. And so this is obviously far less of a dose once we get into the other types of alleles. So the A here is less as far as the AA versus BB is normal, right? This is normal. All right, so on the next slide, it will give more information about the actual base pairs, this and then some others. So for VKORC1, the way they designate this allele is a little bit different because the SNP is not just one SNP. It's actually 4 together. So when you're seeing this reference sequence, it's linked to other SNPs. So they all come in a package together. Does that make sense? So the way that they're naming it, they're naming the whole package. So you have 4 SNPs combined for the package haplotype, which in this case would be VKORC1 STAR2 haplotype. This corresponds to the marker for a low warfarin requirement. And so that's why I designated it here as STAR2 allele. But again, it's not just one SNP, it's 4 together, 4 SNPs combined. 4 SNPs combined, but a very simple naming designation, just to make it easier, shorter in terms of what does this mean? Because really it's the functional outcome that we care about that we're looking at in this case. So this one is not that important, so we're going to skip over this. Just I'll throw it. All right, so this is one of the alleles, again, in this sort of package where we're reporting STAR2. And the allele is a G to A base pair shift. So usually when we see the designation of the base pair, this is how they report it. And what's striking here is that when we look at the frequencies in major race and ethnic groups, we're ranging anywhere from a low of 10% in the African American population to a high of 88% in an East Asian allele frequency. So we're really all over the place in terms of what's going to happen to this package of SNPs on the VKORC1 allele. And that's why we have to consider all of these things together. Because they may not have one, but they may have the other, and then they're going to need less of a dose, or decreasing dose of warfarin. And so here is where they're looking at the designation for the base pair, whether it's GG, GA, or AA. In regards to, they're not calling it a STAR1, they're calling it something different. So GG, this is normal, right? Normal, because we should have the guanine there. We don't want adding there. GA is the heterozygote, and then AA. So this is the mutant. So in other words, this would be STAR1, STAR1. This would be STAR1, STAR2. And as you probably already guessed, this would be STAR2, STAR2. And so on our graph, we started at the low end of 5. So this is a range of 5 to 7 for the recommendation. We started at the low end of 5 and worked our way through. But this information here in this table is the same as what should be in the graph. It's just conceptualizing these two things come together. But I'm a visual learner, so I like looking at the graph first before I look at the table. I like seeing those levels and knowing just conceptually what would be done in the patient and why. All right, so now let's get into far more sophisticated ways of looking at this and what goes into a dosing algorithm. So when we see these warfarin dosing algorithms, which you're going to access and use online, you've got not only the age, height, and weight. You're probably used to seeing all of this, of course. But here, now you see VKORC1, you see A's and G's, which we just talked about, and you see CYP2C9, you see STAR1, STAR2, and STAR3 alleles. And then they also have factors in for races, Asian, Black, African American, missing, mixed race. So all of these numbers are combined into what actually should be dosed. I do not expect you to memorize, okay, if it's the CYP2C9, you're going to multiply that by 0.5211. No, I don't expect you to memorize this, but you should have an awareness of what's actually going into these algorithms. So I ask you on an exam, is VKORC1, AG, is that a factor going into this algorithm? You know, you should be able to say, yeah, because that matters. How you're going to give a warfarin dose, that genetic information is pertinent, absolutely relevant. And again, this is just more information about what exactly goes into that, broken down in a slightly different way, so it's just a reiteration of the previous slide. And this is the warfarin dosing online tool that's going to help us figure out what our patients are going to need, much more sophisticated, and help us sort of go through the dosing recommendations for warfarin based on the genotype for each result. And here we have a strong recommendation to calculate the dose if we have these differences, the shift to A or the star 2, star 3 allele, okay? Everything else is optional, but this is clinically important and relevant. And this is, of course, if we have genotyping information available. That's key. Hopefully, as you guys mature through your career, this stuff will be more automatic and that you would have genotyping information available. But right now, it's absolutely hit or miss. Okay, limitations and benefits. So what I want to do now is work on the in-class assignment. So you're going to be given 7 questions. 4 through 7 are multiple choice, and 1 through 3 are using the warfarin dose calculator, putting in the numbers, and then coming up with the answer. So I would like everybody to turn in their own assignment that I just published. Don't mind if you talk amongst yourselves to help find the calculator, help figure the stuff out. That's fine. It doesn't need to be silent in the room. It doesn't need to be pen drop. I just want to make sure that you're calculating it on your own so that you know how to do it, or you're familiar with this calculator, maybe you've used it in the past, but now we're incorporating the genetic information into the result. So in the assignment, what you can go ahead and do is use the calculator at warfarindosing.org to provide recommendations for a new patient in which their doctor needs a recommendation for the estimated therapeutic dose of warfarin. So again, I'm giving you information, I'm giving you genotypes, and then you need to provide a recommendation. And then we're going to change the recommendation if they're receiving another drug. We're going to take it a step further. And then again, 4 through 7 are multiple choice questions based upon the content that I presented today. I have a Dropbox for this already, so this is all we're going to do in class today. So once you turn this in, that's it. That's all we'll do today. Thank you for your attention. And of course, here, if you have questions, hopefully you guys can access this assignment now.